Good morning, sir. My case today is a 30-year-old female with gravida 2, parity 1, live 1, abortion 1, with 10 years married life with spontaneous conception and previous birth through LSCS. Now came no comorbs. Now came with complaints of fever since 2 days, headache since 2 days, back pain since 2 days, giddiness since last 2 days. Fever was high grade, associated with chills and rigors, relieved with medication, no diurnal variation, no night sweats.
What are the reasons for high grade fever with chills and rigors?
High grade fever with chills and rigors usually seen in pneumonia, urinary tract infections, and can be seen with malaria and
Abscess. Pus in the body.
Pus in the body. And headache was diffuse with a typical history of retroorbital pain was given and not associated with nausea.
Retroorbital pain is seen in which all type of fevers?
Dengue fever, usually associated with dengue fever, and can be seen with any brain abscesses can also
be. Leptospira dengue is the most common conditions, and like you told, any brain infection can also produce that.
Yes, sir. And back pain, it is generalized again, not associated with dysuria. And no other complaints of vomitings, loose stools or abdominal pain or no loss of consciousness, no decreased urinary output, no cough, chest pain or breathlessness, and no bleeding manifestations or rashes. And past history, no comorbs, and previous one LSCS 3 years back, and she is on ecosprin from February, which is stopped at 26 weeks of gestation.
Ecosprin is started for?
Ecosprin, she doesn't know the reason, sir, but usually started in case of fetal heart rate being reduced or high uterine blood flow is there.
What is a common condition ecosprin is started in pregnancy?
Suspect APLA.
Why is not that?
Any
during pregnancy, which condition you start aspirin? Aspirin is ecosprin. Aspirin during pregnancy.
High uterine blood flow is there in
gestation.
Hypertension in the gestation, especially when you are suspecting preeclampsia. That is the most important condition where you start aspirin. But like you told, APLA also you can start aspirin, but there the heparin or the other type of drugs are more important than aspirin.
Yes. Okay. And family history, no relevant complaints in the family or not significant history. Personal history, bowel and bladder movements are regular, appetite normal, and no loss of appetite, no loss of weight, and no addictions. In the menstrual history, age of menarche at the age of 12, and normal flow, no clots. And on examination, she's conscious, oriented, and obeying commands. Pulse rate is 120 per minute. BP was 176 millimeters mercury. SpO2 98% in room air.
What is the importance of pulse rate in patients who is having fever?
Fever, there are usually 1 degree raise of temperature. There is like 10 beats increase. This is normal, sir. Some conditions will also produce bradycardia, seen in usually typhoid fever, Legionella.
Typhoid fever will not produce bradycardia. What is that called as?
Relative bradycardia.
Only a relative bradycardia. It will not produce bradycardia. It is a relative bradycardia. That response you are not seeing, that's all. But there are some conditions where there you get bradycardia and tachycardia. What are those conditions?
Tachycardia and
bradycardia can be there in some type of fevers.
Yes, sir. Seen in Legionella, it can be seen. Malaria, it can be seen. And typhoid fever, it can be seen. Bradycardia. And
dengue is one of the classical conditions. You get bradycardia. That is because it affects the sinus, myocardium and sinus node. That's why.
Yes, sir.
Okay. Tachycardia?
Tachycardia, it can be seen in pneumonia and any abscesses and urine.
Tachycardia means unusual tachycardia. So like you told, when there is a fever, there is a 1 degree rise can produce 10 beats. Okay. But more than that, that is sometimes called as relative tachycardia. Where will you get? One is pneumonia, correct?
Pneumonia, urinary tract infections can also be seen. Any lung abscesses, brain abscesses can also be seen.
Most important condition, if you are seeing like that, you have to suspect myocarditis. Okay. So 2 important things, if you are getting unusually low heart rate, suspect about again myocarditis, but there the sinus node is involved. If unusually it is very high, then also you should suspect myocarditis. Another condition which is producing tachycardia during fever is thyroiditis. Okay, viral thyroiditis. They can have very high tachycardia, thyroid swelling, pain, all these things.
Yes.
Okay.
And respiratory rate is 22 per minute, temperature of 1 or 2 degrees. And pallor is present, no icterus, cyanosis, clubbing, lymphadenopathy or edema, distal pulse is bilateral palpable. Head to toe examination revealed congestion of eye is present, pharyngeal erythema is present, and petechia present on the heart palate.
What are the non-infectious condition can produce petechial rashes with fever?
Conditions with fever.
Chest fee is typically in the lower limb. Very rarely it produces above the diaphragm.
Leptospira.
Non-infectious condition present with fever with petechial rashes in the pharyngeal area. One typical condition you have to tell. What is that? It is SLE. SLE is the classical condition. It's a non-infectious acute inflammatory or chronic inflammation with acute exacerbation. They present with petechial rashes on the pharyngeal area. Okay.
Yes, sir. Okay. Yes, sir. Respiratory system, air into bilateral and normal muscular sounds, no added sounds. CVS S1 is to heard, no murmurs, no raise in GVP, and per abdomen soft and non-tender. Organomegaly could not be assessed. She is 36-week gestation with 4 days, and CNS, no focal neurological effect, bilateral pearl.
Okay.
Yes, sir. And point of care, ABG is normal except lactate being little rise to 3.3.
Okay.
Yes.
So what do you think that 3.3 is significant or not significant?
Significant.
How it is significant?
Dehydration can also precipitate.
Once you see that lactate is elevated, you have to think that there is a reduced perfusion to the internal organs. Okay, you can give fluids or whatever way you can correct that has to be done.
Yes, sir. And ECG is showing sinus tachycardia only, sir. USG screening USG of abdomen revealing noisitis. Okay. And her counts for WBC was 6.26, neutrophils of 75, lymphocytes 10.8, HB is 11.1, hematocrit is 34, sir. Okay. And platelet is 104, sodium is 130, potassium is 3. And bilirubin is 0.6, direct is 0.2 with total protein 6.1 and 3.0 is albumin and globulin is also 3.0. SGOT, SGPT normal, RFT functions are normal, ferritin is also done 164 normal.
Okay.
Yes.
BP?
BP 176.
176? 76.
Yes, sir.
So how do you know that this BP is slightly low? How do you know that is a significantly low BP?
We can assess postural hypertension in the patient.
Okay, so easiest thing is postural hypertension.
Postural hypertension. Then? We assess that, sir, and it was like systolic fall was less than 10. Okay. So it was not there.
There is no postural hypertension, and there is no tachycardia.
Tachycardia is there, so 120, but she was febrile also. Okay. 102. And we can, feeble pulses will be there, with narrow pulse pressure will be there. Okay. Yes.
But what you have to understand is, normally in pregnancy, what will happen to the BP?
BP is
usually. This all we are told about a normal individual.
Yes, sir.
So in a pregnant lady, what will happen to the BP?
BP is usually on the lower side, sir, for these patients.
Lower side or higher side? Higher side. It is always slightly higher than the normal of that patient. I am not telling it is higher than the normal. That I am not telling it is above the 120. Okay, normally these female patients, predominantly they can have a BP of 100 by 90 like that. So it has to be slightly higher. Okay. Here it is slightly lower. That means she is definitely having a fluid deficiency. Whatever may be the reason, it may be due to fever, it may be due to the vascular leak, whatever it is, there is definitely hypotension. Okay. So normally we expect slightly higher BP. Okay. Yes, so we have to keep that in mind. Okay. And lactate is also slightly higher. Okay. Now what other investigation you have done to screen the infection?
CRP we have done, and CRP was also on the normal side. So.
Okay.
Yes, and counts were normal. Ferritin is also like normal.
Okay. Dengue and lepto?
Dengue NS1 was positive.
Okay.
Dengue IgM is negative. Dengue IgG is also negative for this patient.
Okay. So what is your final diagnosis?
Dengue with warning signs belonging to high risk group
Okay.
B2.
She's a high risk patient. She has got mild hypertension. She has got elevated lactate. Albumin is only 3. 3. So slight lower albumin. So that all indicates she is in a state of impending hypertension. Okay.
Yes.
How do you manage this case? What
Like,
are all the things you keep in mind when you are managing this patient?
initially, hematocrit for this patients we cannot consider because patients will third trimester will also have hemodilation, but clinical signs are indicating of dehydration. We have started fluid management, but we cannot give fluids for this patient because they can throw pulmonary edema very easily.
So if you want to see if you want to see whether patient improves with your without any fluid therapy, what maneuver you have to do in this patient? Huh? Passive leg raising is seen in LA. That is a test done in a patient who is having slightly hypotension. See whether the patient responds to your fluid or not. It's a pregnant lady. What is the term? Second term. Third trimester. Lady coming with slightly lower BP. Which maneuver can improve the BP? Which lateral? So you have to keep the patient on slightly on the left lateral position. See that patient improves or not. That is very important. Sometimes on just putting the patient on left lateral position itself, the BP can improve. Why it is like that? What is the reason? Compression of aorta or
IVC.
So normally the gravid uterus will compress on the IVC. Okay, so there will be less return of blood to the heart. Okay, so if you slightly put the patient on left lateral position, then you can see the patient is improving in his BP. So you can unnecessarily avoid unnecessary treating with the fluid. Okay, so that can be tried. Okay, but that may not always work. Okay, only in few patients it will work. Okay, whatever it is, you have started fluid. So how do you assess the patient after giving fluid?
Fluid, we can reassess the BP again, and if BP is improving, or if pulse's adequate volume is achieved, and narrow pulse pressure is also resolved, we can withhold those fluids for these patients.
Okay, then
and
what else is more important in this patient other than monitoring your simple pulse?
Adequate urine output is also should be
that
there.
all we check in every patient. Here, what else you have to see? What else you have to monitor? Fetal heart rate.
Should
So
be
in
monitored.
this type of patients, you have to continuously monitor fetal heart sound.
Yes.
Okay, that is because if the BP is slightly lower itself, the patient like the internal circulation can be compromised. Okay, so we have to be very careful. Okay.
Yes. And thrombocytopenia 104.
It should be treated.
No.
It is not. Okay, we can wait. Okay.
And
suppose this patient develops hypotension other than left lateral position, what else you can do?
We can start IV fluids. If still not responding, we can start one trial with colloids can be also
Which
tried.
colloid can
albumin preferably.
Okay. Albumin is only for colloid which can be
given.
What happens if you give other colloids?
Dextran can accumulate in extracellular spaces, but it cannot be reabsorbed.
Okay.
So it can lead
So
to
albumin
other complications.
can be given. It can also go outside,
but it will
be absorbed to the body. But if you give dextran, it will remain there. But if dextran accumulates in your cells, there is no issue. But if it accumulates in your lungs, okay, then it can produce ARDS like picture, and patient will become very bad very soon. Okay, so we have to avoid such things. Okay.
And still not improving, we can start inotropes, or we can try with midodrine.
Midodrine is same as oral inotrope, but it is better to give inotrope if the patient does not improve.
Yes.
Is there any role for steroids in this type of
steroids? If still not improving on inotropes, we can trial of steroids can be done.
What condition you give steroid? Which is the ideal condition where you give steroid?
HLH conditions we can
That is for HLH, anti-inflammatory. In hypertension, what conditions patient will respond to your steroid?
Severe dengue with shock can also respond to steroids.
When there is an adrenal insufficiency,
Insufficiency.
patient will respond to your steroid. Otherwise, the patient may not. Like dengue, the main problem is what? What is the problem of dengue?
Plasma leakage.
Plasma leakage. Even if you give steroid, nothing will happen. Steroids are only given to avoid the HLH here.
HLH.
Okay, not the vascular leak. Vascular leak is already happened. Blood is going out from the intravascular compartment. You have to give either fluid or albumin, or blood can be given.
Blood can.
Okay, that also can be given if there is a low hemoglobin. Okay, but here the patient has improved with your fluid alone.
Fluid alone.
Okay. And what is this dengue shock syndrome? What are the grades? WHO grades? Grades are there, no? WHO has classified dengue, hemorrhagic fever.
Dengue hemorrhage fever and dengue shock. Dengue hemorrhagic fever and dengue shock.
Okay. So in that condition, this patient comes in which category?
Patient only comes with dengue with warning signs,
Warning sign.
B2 category.
There is no thrombocytopenia.
Thrombocytopenia 104, but no bleeding manifestations are
Okay.
there.
What is the definition of thrombocytopenia?
Thrombocytopenia less than 1 lakh we
1
can
lakh.
consider.
Less than 1 lakh. What are the indications for platelet transfusion?
Less than 10,000 it's an indication, or less than 1 lakh even with bleeding manifestations we can transfuse, or in case of minor surgeries less than 15,000 and major surgeries less than 1 lakh we can transfuse.
So less than 10,000 patient can bleed spontaneously. So that time you have to transfuse. Okay.
Yes.
Why in ITP patient does not bleed even if it is less than 10,000?
Less than 10,000 why ITP does
ITP does not bleed. You might have seen. Okay. So that is a peripheral destruction and the marrow is very active there. So marrow will be continuously producing platelets and these are very young platelets.
Yes.
So they are enough to protect you from the bleeding. Okay. That's why this ITP patients you might have seen, even if it is less than 5,000, 3,000, they may not bleed at all.
Yes.
Okay. But whereas in dengue it's an acute problem, acute destruction, bone marrow is not that active. So first 1 or 2, 3 days there can be a chance of bleeding. That's why we are giving platelet.
Yes.
Okay. What are the types of platelet transfusion you know?
SDP is there and RDP is there.
What is SDP?
SDP is a single donor platelet, and whereas RDP is a pooled platelet from multiple people.
Okay.
But single donor platelet only has one antigen, whereas RDP has multiple antigens.
So what is the advantage? What is the disadvantage?
Advantages: if SDP is given, our body produces specific antibody towards that platelet, whereas RDP, our body will produce multiple antibodies.
What is the disadvantage?
So when we give an RDP transfusion, our body will attack those platelets very fast, so and destruction.
Chronic conditions like ITP and all, multiple transfusions are required. In that type of patient, better to give a single donor platelet.
Yes.
But in acute condition like dengue, who requires only 1 or 2 days treatment, you can give RDP. Disadvantages?
Disadvantage: if they require again transfusion, they can.
Disadvantage of single donor platelet is?
Disadvantage of single donor platelet.
What is the disadvantage? It is very costly. That is the only disadvantage. Very costly. Comparing to other one, it is at least 4 times costly.
Yes, sir.
Okay. So when you give transfused platelets, how long it can stay in your body?
1 to 2 days transfused.
Okay, maximum
platelets.
24 hours. What is the half-life of platelet in your body?
Normal 7 days.
7 days.
7 days.
So suppose some patients are on aspirin. How long the action will stay in your body? Patients are on aspirin.
Aspirin is usually 7 days, sir, but we can withhold it prior to 2 days of surgery.
Why 2 days? It is reduced to 2 days.
Because 30% are only destroyed in the body every day. So we can give, even we withhold 2 days, the new platelets will be formed.
Okay, there is a reason. Now, previously it was thought that 7 days you have to withhold any drug aspirin before any procedure. Now we know that only 2 days is enough, because by 2 days at least 30 to 50% has become new platelets, which is not affected by aspirin at all. So you can go for any procedure after that 48 hours.
Yes.
Okay. This patient is recovered completely?
Yes, sir.
Okay, there is no other issue?
No, sir.
Okay. Okay. Anything you want to add? Nothing? Okay. Thank you.
Thank you, sir.